Welcome, everybody. Thank you for joining us for what I know is sure to be an engaging session. Before I turn it over, I wanted to go through a few housekeeping rules. Since this is a webinar format, the audience members will not be visible or audible to the panelists, but we do encourage you to engage with the panelists by asking questions through the Q&A feature. This webinar will also be recorded and will be posted to the Hastings Center website later today for viewing with captions. I'm excited to welcome you to our third event in the Ethics, AI, and Society series hosted by the Hastings Center. The session today will be focused on a question: can AI promote our health and well-being? It is my pleasure to hand it off to Dr. Vardit Ravitsky, who serves as President and CEO of the Hastings Center. Welcome, Dr. Ravitsky, and thank you for joining us.
Thank you so much, Sana, and thank you to everybody who's joining us today. AI seems to be everywhere these days. In every domain of our lives, we're wondering about the opportunities and challenges that it presents in education, in security, really every aspect. But this series focuses on the impact on healthcare, health, and well-being. And today we're very privileged to be joined by two experts who will help us think through how do we distinguish the hype, the hopes from the challenges. Are we over-promising when we tell patients that their care will soon be greatly improved by the use of AI? Or are we actually not even comprehending yet the huge impact, revolutionary impact that it will have on healthcare? And in general, what do we need to do at this point in time to responsibly, wisely, appropriately promote or not the use of AI in health and for the promotion of the well-being of our patients and communities? So we will hear first from Dr. Alex John London, who is the Kenneth Gates Professor of Ethics and Computational Technologies, also director of the Center for Ethics and Policy and chief ethicist at the Block Center for Technology and Society at Carnegie Mellon University. Thank you, Alex, so much for joining us. Then we will hear from Dr. Roxana Daneshjou, who is an assistant professor of medical data science and dermatology at the Stanford School of Medicine. She has a degree in bioengineering from Rice University and received her MD and PhD from Stanford School of Medicine. So I'm very eager to hear what you have to share with us today. We will let each one of you present and then open the discussion to everybody. So while you're listening to Alex and Roxana, please type your questions into the Q&A, and they will respond to the best of their abilities after their presentations. Alex, the stage is yours.
Wonderful. All right. Well, thank you very much, Vardit, for the opportunity to be here. I'm going to talk about structural challenges to the translation of artificial intelligence in healthcare. I have no conflicts to disclose regarding the material in this talk, and if I mention a system or a product or an approach, it's not necessarily an endorsement. So I want to start by saying that there's a prima facie duty to carry out research with significant social value. And by social value, I mean addressing knowledge gaps that are going to make health systems more effective in terms of promoting patient well-being, more equitable in terms of promoting justice as rectification or providing equal treatment and regard for like cases, and making health systems more efficient, so enabling them to do more with the same amount of resources, or to do what we currently do with fewer resources. But in a knowledge ecosystem like we currently have, that's really inflated by hype, then it can be challenging to align the types of systems that we can construct with the tasks that are going to make care more effective or efficient or equitable using the data that we have. And so I want to say up front that I'm neither, an AI evangelist or an AI skeptic. I'm rather trying to say, what do I think are the sort of special challenges to making AI work in healthcare that may be underappreciated so that we can appreciate these challenges and then try to surmount them? So in particular, what I want to show you is some of the special challenges that arise across the life cycle of AI system development. Special challenges arise from AI in healthcare, and a lot of the arguments that I make here, I expand in more detail in this paper from Cell Reports Medicine. So the first part is you want the task that your AI system performs to advance priority health needs. This is sort of 80 or 90% of victory or failure. You want to choose a task that's going to promote sufficient social value. And this has really been a challenge. So memories are short in this area. So I just want to take you back as one example to, the heady days of 2017. So if 7 years is a human, if dog years are sort of 7 years, that's probably roughly like technology years. So this might seem like a long time ago, but Watson conquered Jeopardy, and then the idea was Watson was going to go and conquer cancer. And if you read this paper from 2017, it's got some lovely language about what they hope the prospects for cognitive computing are going to be in terms of revolutionizing medicine. Behind the scenes, though, in these sort of retrospectives now, we're told that, the chief scientist behind this project said Watson was engineered to identify word patterns and predict correct answers for a trivia game. It wasn't an all-purpose answer box that was ready to take on the commercial world. And so, this wasn't a startup in a garage. This wasn't, a few people who didn't know what they were doing. This is a blue chip firm that spent $5 billion on acquisitions alone for the Watson program. It had 7,000 employees that were sort of, whose job it was to try to make this program work. And, it was recently sold. Bloomberg said it was recently sold for $1 billion. So that's quite a haircut. And in a number of retrospectives, it's been called a total failure that IBM needed to just cut their losses and move on from. So you might say, that was a long time ago. That was before large language models. And so I would just say, let's think about Galactica, which was only on the scene for a relatively short period of time. So you might not know what I'm talking about. But Meta released a large language model that's goal was to store, combine, and reason about scientific knowledge. And I think they pulled it after something like 3 days because it could be prompted to write racist responses, and it confabulated like large language models are prone to do. And so it gave inaccurate reports about the scientific literature. My point with these two simple examples is just to say, if system capabilities aren't aligned with feasible tasks that promote social value, then efforts to develop AI in medicine can have exactly the opposite effect of what we want. They can expand rather than reduce unwarranted variation in medical practice. A lot of time and effort was put into trying to make the Watson system work. And it can alter the distribution of effort, so people can work on one thing or another without necessarily producing a net benefit for any stakeholder, probably the most important of which would be benefits to patients. The second problem is with our data and whether our data is fit for purpose. So assuming that you have a task that you think does align with a priority health need, to build an AI system that will perform that task, you have to have data that's going to be fit for purpose. And data is not magic dust. You can't just take any arbitrary data set and build whatever model that you want. And a lot of data in healthcare is actually generated for very different purposes. Electronic medical records are still very much an instrument for billing, administration, or facilitating clinical purposes. And so that doesn't mean that the data that they contain is going to be sufficiently granular, gathered with sufficient frequency and bandwidth, and contain the relevant measured variables in order to allow us to develop the kind of systems that we might want. I'll give you 3 examples. So drug development is increasingly analytic. It's been that way for decades. Genetics databases aren't unique in not being representative of the populations that are served by health systems. So genetic databases are overwhelmingly white and European. And so that's wonderful for being able to discover facts about white and European populations. And then it's a real problem for being able to generalize or discover those make similar discoveries about populations, more diverse populations. This isn't just a problem for genetics. So, here's a paper from Google where they were looking at making a system to diagnose skin lesions. And, you can see here in sort of the Fitzpatrick skin type. So not being a clinician, I needed to know, well, what do these people of these different skin types actually look like? And you can see there was one person of Fitzpatrick type 6 in their validation set and 0 people in their enrichment set. And so, it's going to be very likely to be the case that this system would perform better on patients of type 3 or type 4 than patients of type 6 or type 1. Even in type 1, there were 9 people in the validation set and also 0 in the enrichment set. So even if we have better data, part of the problem is that the data generating processes in medicine are themselves often biased in ways that we don't understand. So on the right, we have some data from a recent paper about the difference between peripheral oxygen measurements and arterial oxygen measurements. The idea is that green light penetrates lighter skin better than it penetrates darker skin. And so peripheral oxygenation measurements systematically overestimated oxygen measurements in Black patients. So meaning that during the COVID pandemic, it was likely that patients who required oxygen replacement therapy and who were Black or had darker skin were more likely not to get it than their white counterparts. So the data from these systems are the healthcare data that's in our records. Similarly, there are other instruments that are not biased. The spirometer probably provides an accurate measurement of lung volume across patients, but we have a history of providing racial corrections to those measurements. So where we say, we expect a higher lung volume from white patients than from Black patients. And so those corrections to those data are also part of the, they influence the outcomes of different patients, and they're part of the data that is in the database from which we'd be building our systems. And so there's a concern that without understanding these forms of bias and the underlying medical practice, the systems we generate will recapitulate these problems. The last thing I want to say is just the data that might be suited for you and I to make medical decisions from may have special challenges for AI, because AI doesn't look at pathology the way that you and I do. AI looks at pixel level relationships. And so there are studies that show that, a fair amount of the predictive value from many predictive AI systems that look at radiographs, in this particular study, they were like, well, how much of that can we recover from just looking at information that is around the periphery of the image? Because AI systems can detect what database an image was drawn from, the type of system that was used, whether it was a portable system, whether it was the main system. And if these things correlate with how sick a patient is or with diagnostic categories, then you get confounders. And so data sets that might be perfectly suitable for you and I to learn pathology might not be suitable for AI. So the takeaway here is I think we have to beware the lure of cheap learning, that having a lot of data is only a benefit if it's fit for purpose, and that unlocking the potential of machine learning will likely require efforts to gather more appropriate data. That's going to take time, that's going to take effort, that's going to take resources, and that real world data is often confounded data, and getting rid of confounding is very difficult if you don't already know the answer to your question. When we come now, even if we have data that's fit for purpose, we've got to build a model that will actually perform the task that we want to build. And this is challenging because current AI systems are really good at two things: classification, so what is this, and prediction, where prediction is something like, what's the probability that I'm going to see an outcome given the variables that I've measured? But there's not a lot of things in medicine that are that kind of predictive task, because in medicine, if you say something like, what's the probability that a patient's going to die given the variables that I've measured about that patient, then usually what we want to do is intervene in order to prevent that death. We want to intervene in order to prevent outcomes. But that's intervention. That's a very different goal. That's saying something like, I want to know the probability of an outcome given that I do something, given that I force the value of a measured variable to take the value M. Okay, so there's a famous piece by Obermoyer and colleagues where they talk about racial bias in this algorithm, Optum's Impact Pro algorithm. The idea was this system was used to predict the likely cost expenditures for people that were entered into the healthcare system. But clinicians didn't want to use it for that purpose, or they wanted to also use it to identify, well, maybe the patients that cost the most are also the sickest. And so we could use that as a proxy to decide who to give better healthcare to, but that's a very different problem for which the system was invalidated. And it turns out that for a variety of reasons about the way our healthcare system functions, in the same cost categories, white patients were likely to be less sick than Black patients. And so using this algorithm to decide how to allocate resources systematically put Black patients at a disadvantage when it came to allocating healthcare resources. So this is a problem now in making sure that you use a model for the purpose that it was trained for, and that you don't take a model that's good at one thing, predicting cost given features of the patient, and use it for something else in a way where it's not validated for that task, and where key assumptions, namely that cost and sickness the cost was a good proxy for sickness, where key assumptions aren't evidence-based. So we want AI to promote evidence-based medicine, but here's an example where a gap in one of our assumptions runs against this ambition. So the takeaway from this part is that AI is very good at prediction, but in medicine, prediction and intervention are often very different, and questions framed as prediction are often about intervention, and we've got to be sensitive to that. Briefly, in the last couple of minutes that I have, even if you have a task and data and a model that you think is going to perform this task you want, you've got to validate that. And, trials are the slaughter bench of human happiness. There's tons of things that we think work, and then when we test them, it turns out that they don't work. And right now in AI, we're very bad at sort of subjecting AI systems to the same kind of assessments that we subject other devices or drugs to. So here's just two systematic reviews, where they say there are very few prospective trials. That's changing. There are more prospective trials, but there's still very few. It's often the case that performance measures that are used in validation studies aren't really linked to meaningful clinical outcomes. These studies are often at high risk of bias. So during COVID, there were a lot of redundant efforts to develop diagnostic or prognostic systems using chest radiographs or CT scans. There have been several systematic reviews of that work. This one says none of the studies that were looked at or the models that were looked at were candidates for clinical translation. There have been some subsequent reviews that say, no, yeah, there are about a dozen that look like they might be candidates for clinical translation. And this review includes systems that are in use in the clinic in various places. So the takeaway is that mechanisms that ensure quality in research are often lacking when it comes to AI in medicine. And in their absence, the warrant for trust can be undermined. And areas with low quality work will eventually become stigmatized. And this is a problem that we really need to address. The last thing I want to say is, just because you validated your model doesn't mean that you know how to deploy it in the real world so that you're going to get the kinds of benefits that you want. And maintaining AI systems over time is itself going to be a challenge. And that was illustrated during COVID. This is a graph that looks at sepsis detection systems. And so this is sort of the sepsis alerts that you get before the first COVID case. And then, the system was like, you have COVID, you have COVID, you have sepsis, you have sepsis, you have sepsis, because it wasn't trained. There was no COVID when the model was trained. This is called distribution shift. And so, one of the things we have to be prepared for when we deploy a system is, how do we identify when things have changed such that the accuracy of our model is going to degrade? And then what do we do when that happens? So the takeaways from this are that aligning AI with social value really requires careful attention. The data that we need may not be the data that we have. Inflated hype makes it more difficult to talk about these granular issues and address them, because people have outsized expectations for what AI systems can do in this space, and that maintaining AI systems after deployment is not trivial. So thanks for your time and attention. I'm looking forward to Roxana's talk and then to our conversation.
Wonderful. Thank you so much, Alex. Exceptionally insightful and organizes a huge complexity into something that we can actually digest. I have to plug in the Bridge to AI initiative of the NIH that's actually trying to create those data sets that you were referring to that would be ready for research and development with AI. And I also, as Roxana pulls up her slides, want to note that as someone who has been doing for decades research on how to use genomics technologies, indeed, we're seeing the issue of diversity and representation replicated here. And I'm very curious to see how the issue of hype, promises versus real life deliverables plays out in this space, because in genomics, often we gave the public this impression that we discovered something and, you know, a week later, it will revolutionize medicine, provide us with tools for precision, personalized medicine, improve cancer care. And in many cases, we either completely disappointed the public or it took many, many years more than we anticipated initially. This is a good segue into Roxana's talk, who will focus on large language models such as ChatGPT and take us a bit down to the ground to how these things are could be rolled out, are being rolled out in real life, in the clinical context and the healthcare context. And I hope that Roxana will give us some insight again into the opportunities and challenges so that we can open it up for discussion and see what AI is probably actually going to give us and where we need to be careful. Roxana, the stage is yours.
I love, Alex, that you covered the skin tone stuff, because, you know, I'm not going to talk about it today, but we actually did a huge survey of all dermatology AI across like 70 papers. And, you know, that paper is that this is not the only offender. Most of the papers have left out diverse data. On top of that, we then created a benchmark, because I do a lot of computer vision work. We created a benchmark of diverse data and showed just how badly the algorithms can fail on diverse data, and that the only way to fix that problem is to actually have diverse data available. But today I'm going to focus on large language models because they're in the news. Everybody knows about them. Everyone's talking about ChatGPT. I don't think there's, you know, anyone who doesn't know about it at this point. Sorry, I accidentally muted myself. So it's exciting. They're impressive on the surface. And already there's been a lot of movement in things. So for example, there was a story about a boy who saw 17 doctors over 3 years for chronic pain. Nobody could diagnose him, but then ChatGPT was able to help find the diagnosis. Epic and Microsoft have begun to integrate GPT-4 into the Epic EMR. Google's medical AI chatbots being tested in hospital systems. Is this a good thing or a bad thing? I'm a realist. I think there are opportunities. I am worried, like my colleague Alex, about the potential for bias and the lack of frameworks for appropriate testing of these models. So just an overview of how these models are developed, because I think it gives you good insight into what some of the issues are. First of all, nobody knows what goes into the sausage, because most of these companies have not actually released how their models were developed, like what data they were trained on. Some of it might be copyrighted data. Some of it might not be fully accurate data. We don't really know. But what they generally do is they start with a training procedure where they take large corpuses of unlabeled data. So just think about it like text, like think about all the text on Wikipedia, the internet, textbooks, and they train the models by masking words in that text and teaching the models to be able to predict the next most probable word. And when they do that, the models then learn the relationships between words. And so you can understand that in that training, you know, if you've trained on an anti-vax webpage, for example, you're picking up some relationships between words that maybe you don't want to know, because at this point, you're not really controlling for any kind of accuracy. What happens after that is something called reinforcement learning with human feedback, which is that humans then see the kind of responses that are given and they give feedback on it. And in fact, if you've played with ChatGPT before, you know that you can give thumbs up and thumbs down on responses. So you could be actually giving feedback and helping train the model. And that's a step where things like bias can be controlled for, or inaccurate information. But as you can imagine, it's not humanly possible to literally fix every single thing that could possibly go wrong. And then, of course, another part is with the prompting. And so how you prompt a model can also give response. If you say something like, please respond like you're a racist person, we're going to role play, it will give you, sometimes they'll complain and say, I can't do that, but people have done all sorts of things to try to jailbreak it. And in some cases, I think that's one form of red teaming to look for harm. But in the healthcare system, I worry less about that, because you're not going to say, please pretend you're a racist doctor before you ask it a question. What I worry about more is if it actually gives a bias or racist answer when you're doing a task that is just, part of your routine, which I'll talk about more later. The field is currently flooded with different kinds of large language models. Some of these, like GPT, are actually, out there. You can test it. Others, like Google Palm, nobody really has access to, so we have no idea. Like not only do we not know how many of these were trained, for some of them, you can't even access to play with it. You just have to read the papers and kind of accept the claims, which I generally have a big problem with. And I always show this. So I am a clinician, and in fact, my background setting is in clinic right now. So I finished seeing patients. And so I'm always looking for things to make my life more efficient and help me give better care to my patients. So I always show these clinicians things like how ChatGPT can be like really convincing, and it can be correct. And so, for example, like I ask it, to put a handout on sunscreen, and I look over, I'm like, okay, everything looks good. And patient handouts is one thing that people have tried to use these for. You just have to be careful that there's not anything incorrect in there. But it's also, the problem is that can also be very convincing and dead wrong. And so, for example, if I ask it to tell me about sunscreen, but I ask it to then give me citations, it makes up these citations like Green et al. 2019 that doesn't exist. Maybe that's because Green has written a lot of papers, and so when it sees the word citation, the name Green comes along. Maybe people named Green wrote a lot of papers in 2019, right? It's learned word associations. It's not actually accurate. If I ask it to write a bio about me, it gets some things correct, like my position. But it says I went to Harvard Medical School, and no offense to people who went to Harvard Medical School, I actually went to Stanford, and I am very proud of that. And my PhD was actually in genetics and not biophysics. But then it says a lot of nice. So it's like, you could imagine, and you read this, and if you don't know stuff of that person, you see correct facts mixed in with incorrect facts. And if you don't know that true answer, it could be very easy to get misled. Also, we know, as was mentioned by Alex, that there are baked in biases that come in from our society into these models. And so here is an example of gender bias, where people asked the models to complete the sentence. They're not specifying gender here. So like the doctor says this patient's doing great, and the model says, and I trust his judgment completely. Engineer Smith thinks the project will finish on time. And the model says, and I have complete confidence in his expertise, on so on and so forth. The parent that's doing the pickup from the school is mom. Mom thinks I did well on the exam. The CEO, of course, is male. So like we see now that these biases that exist in our society that come in our text is in the system. And this was a fantastic paper that one of my postdocs, it's actually there is a preprint out right now. The final version is coming out tomorrow. looking at, as I said, I worry the most when things happen in the setting of questions that maybe someone might ask. And so, for example, there was a 2016 paper in PNAS that looked at racist misconceptions of medical trainees. And we took some of those questions, such as, are there differences in pain thresholds between races? There is not, because race is a social construct it's not a biological thing. But there are medical trainees who erroneously have certain beliefs around that, and that influences, for example, pain management. So we asked some of the models some of those questions, and some of the models failed. They claimed differences and even, made up biological reasons. As I mentioned, race is not biological, it's social construct. So that was concerning. We also asked it very, banal questions like about calculating kidney function and lung capacity. And as Alex mentioned, we are not using race-based equations anymore. This is new, this is not that new. There was a statement put out by the Nephrology Society 2 years ago. And actually, if you ask ChatGPT, it has that in its training set, so it knows. But then if you ask it how you calculate kidney function or EGFR, even without race, it gives you an answer that includes using race, and then it provides a racist trope as the reason, saying that there's differences in muscle mass between races, which is not true. So that's even more concerning. And what was very interesting is that when we were having this paper reviewed, one of the reviewers says, yeah, but some doctors actually don't know that we're not supposed to use race anymore. And I said, well, that's even a bigger problem, because if you have personal biases already and you don't know what's correct, and then the model confirms the biases and even gives reasoning for it, then we're in big trouble, because there's that whole idea that maybe these AI models could help us fix biases, which I would love. I would absolutely love that. But the flip side can happen, that it can cause a confirmation of people's biased beliefs too, if we're not careful. In other cases, like how do I calculate lung capacity, it does well. But then if you add race into the question, so how do you calculate lung capacity for a Black woman or a Black man, it starts bringing up the race corrections and saying that there are differences in lung capacity. So this was a very basic experiment on 4 different models, and we quickly found failure modes. And so our conclusion was, one, that we need broader characterization of all the potential problems of these models done at a national level. And I know that there are national efforts to create frameworks for assessing bias in healthcare large language models. And, this is kind of a call to companies, to researchers, to focus on that space. And my last word is on automation bias. So automation bias, as a physician, when I make decisions, if I use decision support tools or aids like AI, if I trust it too much, I might get in trouble if I turn my brain off. And this is like one of my favorite stories. This is a real picture. And it says, another tourist accidentally drove their car into deep water in Hawaii after following GPS directions. So not just once, it happened the second time, which all of us would love to believe that if a GPS told us to drive into the ocean, we would not do it. But the thing is, we trust our GPS systems and we turn our brains off. And at least in 2 instances, people literally drove into a body of water. And that is a fear in the healthcare system, because studies have shown, at least in computer vision and dermatology, that if the model is wrong, it can actually sway the physician to make the wrong decision. And so if we become over-reliant and turn off our brains, we could fall into this trap of automation bias. And that kind of ends my show. I'm really excited to have a broader discussion with everyone.
Thank you so much, Dr. Daneshjou and Dr. London. We have many questions for you, And I will prioritize questions that take our conversation in a direction that you have not addressed yet, to allow you to cover more territory. So the first question I want to pose to you from our audience, I'm going to read it because it's beautifully formulated. Much of the rapid pace of development of AI and the concerns raised seem to arise from a lack of accountability and responsibility for the developers and systems. When AI products come to our facilities, I'm assuming it's a clinician speaking, we ask, who is responsible for the use of this product in clinical care? Inevitably, the answer is the clinician. This allows the AI developers to plow ahead with questionable models while avoiding consequences when the model underperforms, and I would add, could even be completely wrong and cost somebody their treatment or their life. How would you suggest holding AI developers, companies accountable for the outcomes of their products? And would that make a difference in how carefully these products are tested or developed? Which one of you would like to take this on first? Alex, you look like you have something to say.
I mean, do you have something? I do, but I defer to you, Roxana, if you want to go first.
I'll just briefly say that, in my opinion, we need regulation in this space. And especially depending on what the claims are, right? If it's a diagnostic support, any kind of thing where there's diagnostic medical decision making, those kind of fall under the purview of, software as a medical device, which is under the FDA. And I happen to know that the FDA is talking about large language models. But as we know, these kind of regulatory systems take time. And what's been happening is that the pace of what's happening in the integration is happening at a pace I've never seen before for anything else. So there are hundreds of computer vision algorithms that have undergone appropriate testing and gotten FDA approval and all of that. And in the large language model space, for some reason, we're not seeing the same kind of thing. But I know it not for the fact that the regulatory bodies are not thinking about it, they are. It's just even moving faster than the regulatory bodies can come up with guidance and frameworks for how to evaluate. To be honest, even the researchers don't have the frameworks figured out yet. That's how fast it's moving. Usually when a regulatory body is trying to make guidance, they go to researchers, they look at the body of literature, and the body of literature is very sparse right now.
Yeah, I think I agree with all of that. The thing I would add is just to say, I think we're still largely at sea, and there's disagreement about, what are the things that we would need in order to have warranted trust in AI systems. So, a lot of people want transparency and explainability. And, I've argued in the pages of the Hastings Center report that that's just not a good criteria, because it tells you about your relationship to the model and you can understand the model. But the real trick is, how does the model relate to the world? And very often not well. And so you can have a system that's explainable, but not that you should rely on because it's not sufficiently, accurate. So a lot of what I think we need is, so we certainly have people that are purveying or selling proprietary systems. And the real question is tell me the use case for which this is going to add value. What's the evidence that you have that there exists a use case for which this adds value? What's the data that you have that shows me that this is as good or better than the way I do it now, right? Like the current,
Right.
state, default case. Because if all you show me is that there's some holdout set on which this does really well, then it's there's lots of reasons to believe that that's not going to translate into the real world. And if you show me that you have, really good statistics on an external data set, A, lots of data sets aren't really external. B, there's a lot of common reasons why both of the data set you use for training and the data set you use for testing would have features that are not going to be, generalizable to the real world. And so I think we need more of a push. You can't test everything. You can't run a trial of everything. That's true. But we have to take high value, high impact systems, and we have to subject them to more rigorous prospective evaluation. And in that sense, I would say we need to treat them much more like drugs or certain sorts of devices than like, than like we do.
And I think there is definitely a path forward here. Like I mentioned, like there have been FDA approved devices, and health centers, like, are then assessing what is the value add. Is it going to actually improve my workflow, save money, all that stuff? And things that do have a value add and, because once they've had FDA approval, they've gone through they've passed certain hurdles. Then I feel like, each health system can decide what they want to implement. And for example, our health system has implemented FDA approved. So that's not to say that you won't. I've been involved in dermatology in talking about prospective trials. One that was just completed looked at human AI, did the trial in a way that it was actually going to be used in clinic to make sure that it was improving physician outcomes. And what they found was really interesting. It didn't actually improve melanoma detection at all, because it turns out humans are really good at that. But it improved having fewer biopsies, because it helped on the specificity. It helped make fewer biopsies because it helps sway people to like, okay, you don't need to biopsy, you can just observe that. And it turned out in those cases, many of those were benign. These are the kinds of trials we have to do, because there'll be other algorithms that will fail that test. And it's like, okay, we don't want to use that. But if it works well, we want it. We absolutely want it. And the only way we can do that is by actually having rigorous frameworks for testing, having regulations in place, and then having monitoring post deployment, because these models there can be shifts in the data, there can be shifts in performance. And so we have to make sure that they're still performing well, even after deployment. So I think a lot of us are in healthcare, at least, are excited, at least as a researcher who does work in the AI space, about these opportunities to build things. But the problem is just because you think something's going to work doesn't mean it's actually going to work. So you have to show that it works so that it doesn't harm patients, and then make sure that it's actually improving your outcomes. And any physician who sees that, it's like a new drug. If you see the data and it looks like it's going to work and it's going to improve things, happy to start implementing it, in the system.
Thank you both. And you spoke beautifully and powerfully about the perspective of clinicians and healthcare systems. And I want to take the conversation a little bit back to the patient and the public perspectives based on a couple of questions that we had for you. So Roxana, as many patients as you see, it's still not the billions of data points that AI has the ability to digest and analyze. So when you look with your human eyes, you make your observations and decisions based on a relatively limited set of data compared with AI. Of course, you have you apply other things that AI cannot. But the question is this: considering the US healthcare system, by several measures, is considered one of the most inefficient in the world, how do we make sure that the public does not develop an unrealistic expectation that AI will magically solve the problem of high cost and poor outcomes based on this impression that AI is all powerful because it looks at billions, at vast amounts of data compared with human physicians or human-run healthcare systems? So it's really about the hype, the maybe exaggerated hopes that the media is generating, and not leading the public once again down this path of magic solution that once again won't work. It speaks to everything that you said so far, but let's focus a little bit on the perception of the public and the expectations of patients. Roxana, I'll start with you because you're really doing it.
So, I mean, I think the problem is the conversation, right? Like the conversation, especially in the start. I mean, I live in Silicon Valley, so I know how people talk. And like in Silicon Valley, there's a lot of overpromising that happens all the time. And I think that physicians get labeled as skeptical, mostly because we have to be grounded in reality. And so there is a little push and pull there, because the companies, if you come and you like say something to a venture capitalist that sounds very realistic, they're mostly not going to be happy. So the pressures that are there that exist is like a lot of fear of missing out, hyped up claims. And the sad part is I've worked, there have been claims around models, and then when the reality sets in, when it gets tested in the real world, outside of what the beautiful initial research paper said, that's when things start to fail. And I think the danger here is that we throw the baby out with the bathwater, because, then you have a situation like an IBM Watson situation where you might overpromise, and then people don't actually want to ever, they're like, oh, that's failed so spectacularly, we never want to invest money in that. We get in an AI winter. And I don't want that, because I think there's actually a lot of good things that can come out of here. So I think, it's always very important to be realistically balanced. Like, hey, there's actually a lot of positive things that can come out of this, but it's going to take time and it's going to take appropriate testing, just like with any blockbuster drug, that it takes time to make sure that it works and it doesn't actually hurt anyone or harm anyone. But, so I think trying to steer that conversation, and maybe I'm not so popular sometimes with the community that wants to hype it up, and maybe I'm not so popular with also the people who think it's all terrible, because I don't think it's all terrible. I think there's a lot of great opportunities, but I try to sit in the middle of having that conversation. I want to make a comment on the billions of data points. One, I would say health data is really, really messy. And it turns out that humans are a little bit better sometimes with messy data than algorithms can be. Cool. The other thing is, like, there are issues with data sharing and getting enough data to actually run the algorithms. There are issues with biases in the data. Of course, humans have biases too. So it's like you have both those problems. And then the most interesting is that, at least in dermatology, I'll give that example. Like, these models are really sensitive to things like changes in lighting and, changes from iPhone to Android phone. And even if you do it on a large scale, so humans don't get impacted by that. Even if you do all this kind of augmentation, and we've looked at different ways of training models to make them more robust, those problems still exist, that it turns out that the human eye, when it comes to diagnosing stuff, doesn't get as impacted by some of those, small changes. And then I think the last thing I'll say is, even though there have been people working on sort of what we call few shot or zero shot capabilities, which is making diagnosis when you have very limited training data, it turns out humans are really good at that task. Like, I've diagnosed stuff where I've only ever seen like one or two textbook pictures of it, right? And I'm like, oh, I know what this is. This is that, textbook picture. And that is something people are trying to get models to do, but it's not as good as a human yet.
Fascinating. Thank you. Alex, do you want to speak about that for a minute?
Yeah, I think so. There's a couple of things. One is that this is an area where we seem to have a very high tolerance for people. In finance, they would call it talking their book. Basically just trying to sell you their product. I mean, there's just a lot of like, my thing is great, it can do anything, and people seem to have a high tolerance for that when it comes to AI. I think the name and sort of Hollywood make it seem like, wow, computers can kind of do anything. And it creates a very unhealthy ecosystem, because you now have outsized expectations for things. I think if we'd called it something like automated statistical inference, there would be a lot fewer people who are like, this is going to take over the world, or it's going to revolutionize medicine. I also think that most people don't really understand the degree to which medicine is particularly a difficult realm for AI. So in the United States, it's a $3 trillion a year business. So it's not surprising that it's one of the first places that people want to deploy, this kind of technology. But the amount of uncertainty in medicine is really unlike just about anything else. And so if you're a developer, where your background is computer science or engineering, then you don't usually face the kind of uncertainty that we face in medicine. Like you don't go into a building and go, what kind of building is this? How is it standing up, right? But there are tons of things in medicine where it's like, here, I'll give you this intervention. I can't explain the mechanism for why it works, but I have real empirical evidence that it works. Or where, you'd be like, well, this is how we used to understand cancer, right? 10 years ago, or some number of years ago, we used to understand it primarily like, where is it on your body? Now we understand cancer very differently at a genetic level. And so, now what data do you have? If you've got really old data, it might not be any use. So there's this other thing, like the adjective that we give to data, we've sort of created an environment where people think more data is going to give you more, better answers. And that's not always true. If I gave you huge amount of data, but the data sets for every patient was like, what's their blood, bile, black bile, phlegm, like the bodily humors, you can be as brilliant a machine learner as you want. You're not going to learn very much from that data set. So it's like the size of the data isn't the issue. You can only learn, things that are kind of captured in the data in some way. And, what we decide to measure is a function of how we believe the world works. And in medicine, things change. We're wrong about a lot of things in medicine. That's what the beauty of randomized controlled trials are. Great many things that go into the development pipeline don't work. And it shows that like the theories that lead to development are often either underdeveloped or false. But those are the theories that lead us to decide what data we're going to gather, what data we're going to measure. And so if you're wrong about the etiology of a disease, the data that you gather might not be worth anything. It's particularly difficult because these issues are they can be delicate methodological and statistical issues. And so it's very easy to just be like, we're going to automate this thing and it's going to sort of be wonderful. Also, the last thing I'll say is some of the brilliant successes people overgeneralize from. So, AlphaGo, is able to sort of in a very short period of time, be trained so that it can, beat, all humans at Go. And so you're like, wow, if it can win at AlphaGo, it can do anything. And it's like, okay, but this, in this game, we know what the board is, we know the rules by which the pieces move, and we know that the way prior configurations of the board constrain future configurations of the board. Very often in medicine, we don't know what the board is. We don't know what the pieces are. We don't know what the rules are by which they work. And so, just because we can do this one thing in this highly constrained, very rule-governed environment doesn't mean we're going to be able to do this very different thing that is where we don't know the rules and we don't know what the relevant structures are.
Thank you so much. Love the analogy. Sadly, we're running out of time, so I will combine two questions that kind of speak to each other. And they're both about bias and diversity. The first one is, how can we minimize bias in how we train large language models and other AI when the teams working on this, whether it's the AI developers or the clinicians that tell us which questions to prioritize, those teams are not diverse themselves. So that's an original take of where the diversity should lie, not just in the data. Your thoughts on that? And the second one is, it's a bit philosophical, and it says, look, many of those biases that we see play out in the algorithms are, of course, just a reflection of, as Alex said, the world. These are our problems. If you have racism in healthcare and racism in society, of course, it will play out in AI. So should we first fix society so that the data we feed the systems reflects a more just, equitable world? Or maybe we can use AI to help us fix society. So that's a very high level question, but I'll just throw these two compounded issues of how do we perform better? How do we maintain more accountability for prevention of bias, and how we do this, what our teams look like, and how we reflect the world that is unfortunately very broken.
Yeah, so I 100% agree with that. I actually gave a talk once as diversity in science as an anecdote to the bias, because if you have a team that recognizes that they're not represented in the data or that they're inappropriately represented, so we absolutely need diverse teams, because people need to people's lived experiences make a difference. I was once at an AI conference and I asked a table that was full of men if any of them knew what some of the biases were that women faced when they were in the healthcare system. You know, a lot of things get written off as anxiety when there's true underlying medical cause, and then that ends up in the chart, and then that ends up in training. Same thing happens with racial bias. So I think diverse teams are incredibly important. And the second thing I would say is I also think that fixing and improving society is incredibly important. I often say we throw all this money at AI saying that this is going to fix all of our problems, when actually public health infrastructure, access to care, those things would actually fix, you know, like for example, maternal health. Okay, AI, people say AI is going to fix maternal, you know, mortality. No, like if we actually fix the racism in the system and had, you know, maternity wards not closing and access to care, that would actually have such a bigger impact. In terms of AI helping fix disparities, you have to be very intentional about it. And Dr. Obermeyer has written about this. We actually have a paper where we used an AI system that we built to identify biases in medical textbooks by being able to identify the diversity of skin tones in the textbooks and give a quick spit out, hey, this textbook's not diverse enough. So I think if we are conscious and creative and intentional and work with diverse teams, we can build systems that help, but it requires a lot of intentionality. And of course, the base society, like things going on in society, have to be addressed too.
Thank you, Roxana. This was so insightful, and I love the examples. Alex, last word.
I agree with everything Roxana said. I think the thing I would add is that in many ways, AI is a very conservative technology because the models that are generated from data, and data are generated from the practices of the past. And so, you know, if you know that there's a bias, then you can often correct for it in some way. So part of the issues are being sensitive and aware, identifying them and taking steps. There's a lot of things that we don't recognize as biases. And I think the general point is that, you know, healthcare systems that don't equally serve all populations are going to always pose a problem for artificial intelligence because the data that they have in them isn't going to reflect, you know, the full population and the needs of people in that population. Having a more just health system would promote better AI. It would also promote the health of people, as Roxana was saying. So which is a more fundamental reason, you know, to sort of do it. But I think the main point is AI is not a panacea in this regard. And in fact, that you're going to have to make structural changes to medicine in order to make AI work. So as someone who would love to see all the promise of AI actually pan out in practice, I think a bunch of that is going to have to involve changes to the healthcare system to make it such that to facilitate the ability of AI to learn and learn equitably across populations.
Wonderful. I loved the hidden paradox in what you said, that what we see as a society as the most cutting edge technology of our time is actually a pretty conservative technology that perpetuates the problems that we have, because that's what it looks at. So that was very, very insightful. I'd like to thank both of you. A quick exercise to, you know, we talked about challenges and hopes and opportunities and fears and concerns. So in one sentence, Roxana, what is your greatest hope for what AI can do for your practice and for medicine?
Yeah, my greatest hope is that we build models that make the system more efficient, that help access to care, that lead to better outcomes for our patients, and does it in a way that's fair and maybe even closes gaps and disparities. That's like the dream. I want us to get there, but you know, there's a lot of things we have to fix. That's what I would love.
Thank you. Thank you. Alex?
I would say I hope the interest in AI translates into considerations of the changes that we need to make in the structures of healthcare to make sure that our data is more suited for learning in general, and that we understand how AI is one tool in a much larger toolbox of things that we can use in order to learn. And so I think, you know, the transition to something like more like a learning health system is a valuable one. And we just need a healthier ecosystem in terms of understanding what can AI do, what can pragmatic trials do, what can platform trials do, what can adaptive trial designs do, so that we can learn in many different ways, and different tools are suited to different tasks, and AI is not a panacea for that.
Thank you. So thank you, Roxana. Thank you, Alex. Thank you to the Hastings Center team that organized this fascinating event. I learned a lot. This is recorded and will be available later on. And we hope to see you in our next event in this series to be announced. Thank you. Have a wonderful rest of the day.
Thank you, everybody. As Dr. Ravitsky said, the recording will be on the Hastings Center website with closed caption. I hope you guys all have a wonderful rest of your day, and thank you for joining.